session.
Thank you, ma'am. And we now have the next session, next panel discussion. And may I please invite Dr. Sumit Goyal, Dr. Tapan Sarkar, and Dr. Rishi Parmeshwar, eminent surgeons from UK, to kindly moderate the session.
Good morning, everyone. Sumit, do you want to go? Do you want me to? I think we have a group of friends here, both as moderators and panelists. We'll just work together, not cause much of confusion.
I think, Rishi,
please go ahead, Sumit.
If we go in the order of the presentation, and the first presentation is from our dear friend Jayant. And Dinesh, are you going to introduce Jayant?
I will introduce. Dinesh is not here, so I'll.
Okay.
So, well, this is an easy job, isn't it? This is an interesting session because all the trials we are going to discuss, they are of practice-changing importance. And COVID has only highlighted the importance of all these trials. And I'm sure people will find it quite interesting. My job is quite easy. I have to introduce Professor Vaidya, who doesn't need any introduction. But this is a formality. I have to do this. Professor Vaidya is Professor of Breast Surgery and Professor of Oncology at University College London. He is an eminent researcher, and he has done groundbreaking research on intraoperative radiotherapy, and he's known worldwide for his contributions. He is a member of various committees, and he has published over 250, 300 papers. So I wouldn't take a lot of time because it will take good 5-10 minutes to just bullet point his achievements. So I would like to invite Professor Vaidya to talk about IORT and its impact and potential impact on breast surgery, breast cancer management. Professor Vaidya.
Thank you very much for your real kind words, and thank you very much for inviting me to give this talk. I want to be sure that you can see my slides. So, is it clear that everybody can see the slides and hear me?
Not so we can hear you, but we can't see the slide.
Okay, 1 second. Well, we tested it in the morning. Your screen sharing, it says. I'll stop sharing again. Share screen. PowerPoint. Share. Can you see it now?
Yes, sir.
No, good. Okay. So then. Okay, can you see the full screen?
Yes, sir, we can see the full
Good,
screen.
good. Thank you very much. Sorry, I'm going to try and condense this in 10 minutes. So I shall be giving results of the Target A trial, the long-term results, and also give some background with relation to other trials addressing the similar population. So acknowledgements are really due to all patients in all these centers, all the investigators, and the teams around the world. So these are the authors of the latest BMJ paper, declaring my potential conflict of interest, funding from NIHR, HTA, and honoraria from, and some travel reimbursement from Carl Zeiss. So this is one of the trials that actually started in India. So I used to tell as a senior resident in Tata Hospital, patients coming from all over India to say you have breast cancer. And the next question I had to ask is, can you come to Bombay or stay in Bombay for 6 weeks or come to hospital every day for 6 weeks of radiotherapy? And if they said yes, we could preserve their breast. But if they said no, we said, well, you have to have a mastectomy. And that wasn't a very nice thing. And this is not limited to India. It is there across the bridge in UCSF in California, in Australia, Denmark, and UK. So this is not a unique problem to India. It's there all over the world. So this concern about patients and the curiosity about breast cancer led to this study of whole organ analysis of mastectomy specimens, which was performed in Tata Memorial Hospital. And there I used to do the mastectomies, take them to the lab and freeze them and slice them. And what we found is that breast has many other microscopic cancers, but these microscopic cancers seem to be indolent, and we get local recurrence mainly around the area of the primary tumor. And this was published and presented and gave to the idea that it is sensible probably to target radiotherapy only to the tumor bed. So this was an academic insight to give radiotherapy to the tumor bed during the operation, led to the collaboration with the industry to develop a new device and a new technique to perform clinical trials to test the new approach based on the principles of immediacy and precision. So that is a photograph from the first case in July 1998, and that's how it looks in the operation theater. You can see there Professor Baum and Professor Tobias in the operation theater. So this is for the surgeons in the audience, where you can see how a purse string is taken after tumor has been excised. It is carefully taken to make sure that you don't come too close to the skin, but oppose whatever the tumor bed is. So green here is a tumor bed, red is the purse string, and this applicator takes the place of the tumor excision, excised specimen, so that the tumor bed opposes the applicator. This is a very meticulous and clean technique that the surgeons need to do very carefully. So this is how it looks in the operation theater. That's the applicator in the tumor bed. We are doing it during COVID time. So this is a photograph of one of the patients done recently, and that's how it looks in the operation theater. So radiotherapy is delivered immediately after lumpectomy. It is focused to the tumor bed and targets the tissues at highest risk of relapse. In the process, it avoids nearby vital organs such as the heart and the lung, and is based on the principle of immediacy and precision. Various size applicators are available for various sizes of tumor bed. So it is finished during the operation. Patient wakes up, and that's all that should be required in 8 out of 10 patients. So the TARGET A trial asks a simple question: can this risk-adapted radiotherapy replace the usual post-operative radiotherapy? So for eligibility, this is important. Patients had to be 45 years or older with unifocal invasive ductal carcinoma on normal imaging. Tumor size preferably less than 3.5 centimeters, because the biggest size applicator is 5 centimeters. MRI is not required, and only 5 to 6% of patients in the trial had MRI scan. The randomization is between 2 approaches: risk-adapted radiotherapy versus normal whole breast radiotherapy postoperatively. By risk-adapted, it means that if specific factors such as lobular cancers or positive margins are found, then patients can get whole breast radiotherapy in addition, which happens in about 20% of patients. So the first results were published in July 2010 in the Lancet, and the second results were published in 2013. These were 5-year results. But breast cancer has a long natural history, so long-term outcomes are important. And you must recognize that the first patient was randomized in this trial in March 2000. The data lock for this analysis was on 3rd of July 2019. So we do have a very long follow-up. But what we needed to do was to have complete follow-up. And for this, we set the bar really high. By that, the follow-up was considered complete only if 95% patients had at least 5-year complete follow-up, and 90% patients had either 10-year follow-up or were seen in the previous year. After having this complete follow-up only, and only after that, the data was unblinded and sent to the statistician. So because of all this, TARGET A has the largest amount of follow-up data amongst partial breast radiation trials for invasive breast cancer. You can see this skyscraper plot in which these are the patients at various time points of follow-up in the TARGET A trial compared with other trials. So it has obvious advantages to the patient. Surgery and radiotherapy is completed at the same time. There is less travel, there is good cosmetic outcome, there is less pain and fewer complications. And I don't say this just out of my head, but there are multiple studies that have shown this to be true. I can't show it in these 10 minutes. So that is all very good. But the patient has one question in her mind: what is the chance of my living without the cancer coming back? And that is the crucial question that was asked by the TARGET A trial. So here are the results. So these are long-term results. You can see the x-axis goes up to 12 years. The blue line is external beam and the pink line is target. So the lines are on top of each other here. For local recurrence-free survival and invasive local recurrence-free survival, no difference was found. Mastectomy-free survival was similar in both arms, and so was distant disease-free survival. The next was the mortality. And here the graphs are magnified, and you can see breast cancer mortality was very similar in the two arms of the trial. But this was the result which was seen 5 years ago, 7 years ago, and we have seen it again, that non-breast cancer mortality was significantly reduced in the TARGIT IORT arm, and overall mortality, the TARGIT IORT arm figures were lower for mortality than EBRT. So the first patient was randomized in year 2000, and in 2010, Lancet put our results on the front page that for selected patients, TARGIT should be offered as an alternative to external beam radiotherapy. 10 years later, 20 years after starting the first case, we have now shown, the results show that the breast cancer control is comparable to EBRT, and there is reduced non-breast cancer mortality. So these are the results in a single slide: local recurrence-free survival, mastectomy-free survival, and breast cancer mortality. There is no difference between the two arms of the trial, whereas for non-breast cancer mortality, there's a significant reduction, a 41% reduction in relative terms for giving TARGIT IORT. And if you see the absolute numbers, it's about nearly halving it, 9.85% reduced to 5.41%. Now, is this plausible? It is plausible. It is very well shown that whole breast radiotherapy can cause myocardial perfusion defects within 6 months. There are many other studies that support the harmful effects of whole breast radiotherapy, and the evidence about breath holding is not yet there in randomized trials. And this reduced mortality in TARGIT IORT compared with the whole breast radiotherapy is consistent with other PBI trials, as you can see in this meta-analysis, which we published 2 years ago, where there is a reduction in non-breast cancer mortality and overall mortality with partial breast rather than whole breast radiotherapy. One point I want to make clear is that TARGIT had a substantial high-risk population, typical of a cohort seen in our breast clinics. So 85% patients were under the age of 70, 20% patients, 443 patients, not a small number, had grade 3 cancers. Nearly 500 patients, that is 22% of the patients, had involved nodes, and 19% were ER or PR negative. So it is not a low-risk population, and is much higher risk than trials of no radiotherapy. And in fact, four-fifths of the patients who were in this high-risk group did not receive the supplemental EBRT and received only TARGIT IORT. So they're not the ones who got both treatments. So it is much better than giving no radiotherapy. And these are trials of no radiotherapy. The most recent one is the PRIME2 trial. And you can see that the numbers were smaller. They were very low risk group, that is more than 65, whereas here there was no reason to have elderly patients. There was no restriction on tumor size really or grade, and patients did not have to be node negative. So you can see here, nobody was over 65 in PRIME2, whereas 60% were over 65, 2% were grade 3 versus 20%, and so is the situation with node positive. And despite this higher risk population, the TARGIT IORT local recurrence rates were 2 to 3 times lower than no radiotherapy. And which patient would not want to have a local recurrence risk of 1 in 48 compared with 1 in 17 or 1 in 25 with no radiotherapy? There is one more trial I want to give importance to here, because it has been promoted and even started use before it was published. It is the Fast Forward trial. And there is a misconception that this is partial breast. It is not. Fast Forward is whole breast. It does require 7 to 15 extra visits, including the boost, planning, and consultations. There is higher toxicity. About a quarter of patients report having hardened and firm breast. And this breast duration, as per physician assessment, is also 19 times more. There is still scattered irradiation to vital organs, and no reduced mortality was seen in TARGIT in Fast Forward. Whereas for TARGIT, in 80% of patients, there is no extra visit. There's lower toxicity, better quality of life, less pain, and almost zero scattered irradiation, and a significant reduction in non-breast cancer deaths. So for my personal view, I would give a thumbs up to TARGIT here. And for brachytherapy, other types of partial breast radiation, again, these were low-risk patients for both brachytherapy and external beam partial breast radiations. Breast cancer outcomes were similar. The number of patients was smaller than in TARGIT A, and toxicity was more. There are wire entry scars present. And I think these are the photographs which patients should be shown before they are given choice about which type of treatment they should receive. So for a medium risk population, IORT seems to have a lot of benefit. And of course, you may call me biased, but this is the data that is what should be used for treating. So it's not just me who gives thumbs up to this. This has been used all over the world. And these are user meetings in US, in Europe, in Bangkok, and in Europe, in US again. And we do these every year. And this was a paper that is submitted for publication in which I got data from 260 centers in 38 countries who have used Target IORT around the world. Each of these dots are centers which have offered IORT for their patients. And in total, over 45,000 patients have received Target IORT around the world based on the randomized evidence presented in the Target A trial. I want to leave you with this last video.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had Target IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had Target. I am so happy I was able to have this treatment.
So it has now been used in over 45,000 women around the world, I believe. And I started this with the hope that this is available in India. And I believe it should be made available to suitable patients all over the world. In the UK, this option is now law and GMC guidance. Thank you very much.